cardiac fontan completion EHJ-7. He developed PLE, ascites, and pleural effusion despite optimized therapy. And then he referred to our center, where after a multidisciplinary discussion, he underwent to the fenestration of the extracardiac conduit. At first, fontan conduit was optimized with the implantation of an non stent, which was subsequently postulated by high-pressure Atlas balloon. Then the fenestration was created by using a broken broth needle, which was sequentially dilated by high-pressure Manson balloon up to 9 mm, in order to prepare the landing zone for the implantation of the 8 mm AFR with a final fenestration of 5 mm. The final pressure within the fontan conduit was 50 mm of mercury, with at the cost of oxygen desaturation. During the observation in the recovery room, we noted a sudden increase of oxygen saturation, and given the suspicion of thrombosis of atrial regulator, confirmed by the echocardiography, we administered one single heparin bolus with a complete resolution of the thrombosis. Then the patient was discharged on rivaroxaban. After 1 month, during a cardiologic follow-up, an increase of oxygen saturation and atrial regulator obstruction were detected. So we decided to bring back the patients in the cath lab, where the baseline angiography confirmed the complete occlusion of the atrial regulator device with a certified thrombus around the device. An initial attempt using multiple guide wires was successful. Then, after multiple attempts using snares and various biopsies, the device was successfully retrieved by Blanca grasping forces.
That's okay, as long as you're here, that's the most important thing.
The retrieved device was completely thrombosed and partially endothelialized. But after we identified a new thrombosis formation within the fontan conduit, therefore we promptly secured the fenestration by the implantation of a pulmonogenesis stent across the fenestration with a final fenestration of 5 mm. Then, in order to avoid a paradoxical embolization, we performed a temporary balloon occlusion of the fenestration by using an inflated mini shot balloon. And after, we performed thromboaspiration using a 5 French Sophia and a 6 French penumbral neuromax aspiration catheters. After the thrombosis fragments were retrieved by manual aspiration. And at the end, two-loop injection recombinant tissue type plasminogen activator were administered for a complete thrombolysis. This is the panel angiography, which shows the restored flow across the fenestration, and despite the improvement of thrombosis, it persists, some materials, some thrombosis materials persist within the fontan conduit. The patient was extubated the next day without non-neurological sequelae, and the CT scan documented a minimal residual thrombotic acquisition in each part of the conduit. An aspirin was started, followed by warfarin with a target INR between 2.5 and 3. And a 6-month follow-up, the patient was clinically stable with a patent fenestration and a significant improvement of PLE. Now, what about atrial regulator? AFR has been increasingly adopted off-label in order to create a calibrated shunt. In the fontan failure setting, is used to reducing elevated systemic venous pressures. AFR is a double-dish nitinol wire mesh with a center of penetration which ranges from 4 to 10 mm, but only 8 and 10 are CMR. From a technical standpoint, before the implementation of the airflow regulator, we performed our pre-dilatation using high-pressure balloon in order to minimize the sensing compression of the device. The final fenestration was approximately of 5 millimeters in order with our hemodynamic target desired. But despite these, AFR thrombosis occurred, and this reflects both the size-related low flow condition and prothrombotic influencing Fontan environment condition. Now, 3 points make this clinical case very relevant. First of all, the retrieval device was very challenging, but Maglanka, where his forceps proved the grip and the grip the control we need, outperforming standard biopsies in a partially adherent device. Second one, with the fenestration, in order to avoid a paradoxical embolization, we performed a temporary occlusion of the fenestration with inflated mini shock balloon. So this case raises the question whether dedicated embolic device such as Spider or Sentinel can enhance the procedural safety in these complex scenarios. And third, we used some aspiration catheters that allowed satisfactory clot removal, suggesting the advanced of this vacuum system. We should remember that these two kinds of aspiration catheters are adopted off-label in congenital interventions. And the last but not the least, what about dogs in Fontan patients? A full rivaroxaban was used. Current evidence supporting the use of direct oral anticoagulant in Fontan failure patients is still limited, particularly in this early post-implantation phase when thrombogenic risk is highest. In contrast, vitamin K antagonists may represent a safer option for this high-risk period. In conclusion, AFR thrombosis is a serious complication, but it could be effectively managed with a tailored percutaneous approach, and it's essential to have carefully plan the procedure and to have a thoughtful anticoagulation strategy. Thanks for your attention.
Thank you very much, Maria Teresa, also for being in time. I'll just give the word to the jury to see if they have any questions for you. Also, the people in the chat, they are in the webinar if they want to write in the chat any questions. Yeah.
So I should read the question and...
No, don't worry, I will read it for you if they are coming. At the moment, there are no. Ina, do you have any questions or so, David?
Yes, I'm deeply impressed about this case you managed. I would have 2 questions for you. So if there would be a second patient like this, would you, when implanting a stent in the conduit, would you probably use a special stent, an open cell stent, something like that, to allow full expansion or full pre-dilatation and expansion of the AFR? Do you think this has any input or any effect?
Okay, so in another kind of patient, you say, okay, in another patient with the same Fontan setting, Fontan failure patients, I probably preferred always the AFR implantation, because I think that anyway, the kind of this device is its configuration is less thrombotic than the stent configuration, because there is less protruding material. So I think that in consideration of the prothrombotic high risk of this Fontan physiology, maybe AFR can reduce the risk of prothrombotic thrombosis. Anyway, we performed a pre-dilatation in order to minimize the sensing compression on the device, but we used a Masson balloon up to 9 millimeters with an AFR of 8 millimeters. So generally it should be +4, and because we would like to obtain a final fenestration of 5 millimeter, that is our hemodynamic target for this patient to avoid desaturation.
Absolutely. And do you think a normal stent, a covered stent, something like that, would have any advantage versus the AFR? Because you have this AFR, it's a disc, and it has to fold in some way within this conduit.
A cord stent, I think, in my opinion, can increase maybe the risk of thrombosis, because it's like another tunnel in conduit within the the frontal conduit and the atria, and can alterate the flow of the blood flow, so can enhance the risk of thrombosis.
Okay, and you would say we would try to have an 8 millimeter fenestration to end up with at least 5 millimeters. That's what I got, right?
Yeah, our final fenestration was a 5 millimeter, because we should avoid the situation.
Yeah, this could change a bit in terms of when hemodynamics change, the hole might be too big or too small. Thank you very much.
Can I ask a question, Maria?
Yeah, colleagues, yeah, please.
Thank you. Great presentation. Sorry, I lost a little bit of it, but I guess my question is around the thrombosis and the anticoagulation protocol. So rivaroxaban in young patients, bit of a mixed feelings on it. Did you think if you used warfarin or antiplatelet agent, maybe less chance of thrombosis in this patient?
Thank you for your question. It's a very interesting point, because at first we used the rivaroxaban for increase the compliance with the patient because he's a child, and probably considering the tendency of these patients, because the first time he developed thrombosis after the cath lab during observation. So probably, in my opinion, yeah, enoxaparin and the warfarin, and after using vitamin K antagonist could reduce the risk of a thrombosis. In fact, the last time we discharged the patients with warfarin, and the patients was good with the fenestration. I can share again the slide to show you the flow during the cardiological follow-up. Here, this is the second fenestration.
No, very nice. Yeah. Great. Congratulations on a very nice presentation, Maria. Thank you for answering the question.
Thank you. Thank you. Very brilliant presentation, and thank you for answering so well to the questions. As you can see, I will leave a bit more time for questions, so at least 2 minutes if there is anyone shy, but I think they are a great point. Maria Teresa, I will ask you to stop sharing, and I'll ask Andrea Greco, the next presenters, to start sharing. So Andrea Greco comes from Spain. He's going to present a case of severe neonatal long QT syndrome type 3 with a de novo SCN5A inactivation gate variant, genotype directed therapy combined with early LCSD. Thank you so much, Andrea.
Thank you. Very long title. Very long title. So, good afternoon, everyone. It's a pleasure for me to present our case. So, as you know, long QT type 3 is a severe sodium channelopathy that may already manifest during fetal life with persistent bradycardia, and in its, sorry, I take this one, and in its most malignant form with functional 2-to-1 atrioventricular blocks. So, these early manifestations usually reflect a marked QT prolongation and measured electrical instability, carrying an high risk of ventricular arrhythmias. So, starting with the patient information, this was a fetus from a 40-year-old pregnant woman, initially followed at another center. During the first trimester, morphological findings were normal, but in the second trimester, blocked premature atrial contraction were suspected, and at 36 weeks, the patient was referred to our center for a fetal bradycardia. So, as you can see here, the cardiac morphology appears abnormal with a globular shaped heart and atrial dilatation, but importantly, mitral aortic pulsed Doppler showed a regular atrial rhythm with a constant A to A interval and a 2-to-1 atrioventricular relationship. So these findings strongly suggested that this was not a simply ectopy, but rather a functional second-degree AV block. So the parents had normal ECGs, and maternal anti-Rho serology was negative, so making the immune-mediated AV block unlikely. And finally, because of persistent fetal bradycardia, the delivery was performed by a cesarean section at 37 weeks. So going to the physical examination of this patient at birth, the neonate was clinically stable, normal weight, up and APTA score with a remarkable family history. But talking about the diagnostic assessment, the postnatal diagnosis includes the ECG, the echocardiography, laboratory studies, and genetic testing. But ECG was immediately the key investigation. So this shows a sinus rhythm with an air rate of around 50-55 beats per minute, a functional 2-to-1 AV block, and an extremely prolonged QT interval up to 820 milliseconds. So in this context, the apparent AV block is actually a functional AV block caused by an extreme prolongation of the ventricular repolarization in this case. So these lines highlight how similar was the fetal Doppler findings and the postnatal ECG pattern. Then the echocardiography did not show significant structural heart disease. Laboratory studies were unremarkable at the first days, and in this time, genetic testing was ongoing. So go through the medical intervention during these days. Already on the first day of life, congenital long QT syndrome was suspected by our team, and beta blocker therapy with propranolol was started. So by the first day of life, the patient still had persistent functional 2-to-1 AV block alternating with periods of 1-to-1 conduction, but suddenly he develops this episode of no sustained ventricular tachycardia in the form of torsade of the points. So these episodes were initially limited, but clearly indicates a malignant phenotype of this patient. So at this age, magnesium sulfate and esmolol was added, and taking into account the repeated episode of no sustained ventricular tachycardia and TBP, we escalated the treatment on day 8 of life with a left cardiac sympathetic denervation and an ELR implantation. So despite an initial stabilization of the electrocardiogram, the QT interval remained markedly prolonged with persistent 2-to-1 AV block and baseline bradycardia during the episode. So we decided at 50 days of life to perform a lidocaine test. So during the test, after lidocaine infusion, as you can see here, DCG showed a clear QT shortening and transition to 1-to-1 AV conduction. So it was clinically very important because it supported the presence of a late sodium current mechanism consisting with the long QT syndrome type 3 and guided the introduction of mexiletine as a target therapy in this patient. So between 50 and 30 days of life, the QT interval improved, although some ventricular arrhythmias still occurred, so treatment was optimized. We suspended propranolol and we added flecainide together with mexiletine and magnesium. So then moving to the outcomes and follow-up, by the time of discharge, this was the ECG, with a normal heart rate and 1-to-1 AV conduction, with a QTC of 550 milliseconds, more or less. So finally, we had the result of genetic tests that identified a de novo SCN5A variant confirming the long QT type 3 diagnosis. Then at 2 years of age, a single chamber ECD was implanted, but later, at 2 years and a half, after several appropriated ICD shocks during some ventricular tachycardia episode, the system was upgraded to a dual chamber ICD. So we have the opportunity, the possibility to increase the dosage of medication, and above all, to add propranolol to the basal treatment. At 3 years of age, epilepsy appeared, also in association with this SCN5A mutation, and anti-epileptic therapy was added. And these two medications that primarily act by blocking the sodium channels. At 7 years, the ECG still showed a repolarization abnormality, with, in this case, a natural pacing of 80 beats per minute, and a QTC of 510-550 milliseconds. So the patient remained on a complex treatment, including flecainide, mexiletine, propranolol, and magnesium, associated with valproic acid and oxcarbazepine from the neurological point of view. So going to the discussion, neonatal long QT type 3 is a particular high-risk phenotype, especially in fetus and neonates with SCN5A deleterious variant and 221 AV block. Long QT syndrome type 3 can show severe neonatal outcomes in some studies, and QT syndrome type 3, the arrhythmic events are often bradycardia triggered, which may explain our breakthrough of TDP or torsade point on beta blocker therapy. So our management strategy is consistent with contemporary expert guidance, which support a timely escalation, and moreover, in our patient, left cardiac sympathetic denervation successfully suppressed the current TDP storm, consistent with previous pediatric reports, and to our knowledge, this represents the smallest infant in whom a left cardiac sympathetic denervation has been performed and reported today. And although this variant is de novo, is novel, a variant affecting the same codon has been associated with gain of function of long QT and long QT type 3 and mexiletine responsiveness. And finally, the lidocaine 10 demonstrate the marked QT shortening and support the initiation of flecainide or mexiletine, later complemented by flecainide for an additional QT improvement. So in conclusion, neonatal long QT syndrome type 3 can present from birth with malignant arrhythmias, particularly in the setting of extreme QT prolongation and functional 221 AV block. So every aggressive multi-modality management, including left cardiac sympathetic denervation, close rhythm monitoring with implanted loop recorder, and genotype-guided sodium channel blockade may be life-saving. Provocative testing may help identify the most effective target therapy, especially mexiletine, like our case. And above all, long-term stabilization may require ICD implantation, tailored antiarrhythmic therapy, and multidisciplinary follow-up. So thank you very much.
Thank you, Andrea. Beautiful case. Thank you for being on time as well. I'll just ask the jury if they have questions. Also the audience, please. David, please go.
Thank you very much. This was a great presentation and a really interesting case, quite challenging and impressive long-term follow-up too. I mean, you followed for several years. Now, my question, I have several questions, but maybe only one for just starting. For me, I didn't really understand, when did you set the diagnosis, this is long QT syndrome type 3? I had the impression you waited for the mexiletine test or something, but actually when I saw the ECG, this was already the phenotype I would expect for a long QT3, you know, the flat line and then a late T wave. What would you say, when is the diagnosis set, and all the other therapeutic challenges, of course, come after the diagnosis? But maybe you can extend that.
Correct. Thank you for the question. We have, as you know, the suspicion was from the fetal life, no? Because with this 221 AV block, something that in another center they say probably there is something ectopy of the atrium, something very strange. And normally, we know, and like in the discussion we discussed this, no, the long QT syndrome type 3 could be very normal, no, with a normal QT, or in fetus or neonatal period, usually they are very aggressive, very malignant. So the suspicion, we have the suspicions from the fetal life, 37 weeks of gestation. But the real diagnosis probably was after the lidocaine test, when we see this shortening of during the lidocaine test. I say that, but I'm not here in this case in 7 years ago, more than 7 years ago. But what they say to me was that the diagnosis was real in this after the lidocaine test, when they start the mexiletine infusion treatment.
Yeah, I mean, I know that you will not have done this years ago. I appreciate this. I would not fully agree that this is the diagnostic step to settle the diagnosis. That's my only point. But of course, the value of this case is not the lidocaine challenge. Maybe one final question. I'll leave this to the other. But the interesting point is also the AV block at the beginning, which is not not expected in this situation. And then providing a beta blocker is not completely intuitive, I would say. How would you recommend to approach that, and why would you dare giving a still propranolol in this setting?
Correct, great question. It's true. It's one of the points that we made a mistake. Probably it was not our mistake from the cardiology part. Was the treatment that neonatologists start after when these child born, and they start propranolol in the idea of to put some beta blockers in a long QT. No, they know long QT beta blockers. So they start propranolol. They start the infusion of propranolol. Then when we see this, it is normal, no, with a 2-to-1 AV block after after birth, and then when they start the propranolol, this was the first trigger of the torsade point. A lot of time, because not they are large. They have a large part of the activation, ventricular activation. So we stop the treatment with propranolol, and then we start again the treatment with propranolol when we can start to doing the atrial pacing. When we upgrade the ICD with a bicameral ICD at 2 years and a half of age, we can start the atrial pacing, so we can put the propranolol. We reduce a lot the ventricular tachycardia in this patient, also with the mexiletine and flecainide treatment. But a good question, a good point.
Thank you very much.
Any other one from the jury that have questions?
Sarah, I think there are in the FNA, there are some questions. Perhaps we should allow these first. I have quite a lot, please.
Yeah, it's okay to make a lot of questions. Yeah, totally. I have Christoph, that Andrea, you know very well from the working group.
Yes.
That is complimenting for the case, but he's asking a few more questions about the medication. Like, first of all, why did you add flecainide? Because maximal dose of mexiletine or mexiletine side effects, I think is connected to why you add flecainide. Yes. Which were the doses of flecainide and mexiletine?
Right now, yes. For the first question, thank you, Christopher. For the first question, yes. For this reason, he had a side effects of mexiletine. So we try to reduce the doses of the mexiletine, and then we grow up with the doses of the flecainide. Probably is not a real connection between the effect of flecainide. Probably all the effects for shortening this QT in this patient is from derived from the mexiletine, not from the flecainide. But it's very difficult right now, 7 years later, to take off one of these medications that we don't know which of these medication had this effect. And right now, mexiletine level are in the last evaluation 11 milligrams per kilo day, and the flecainide 4 milligrams per kilo day.
Okay.
Divided in 3 administration. Yes.
Ina, you said you were having other questions. We can allow maybe one question more.
Yeah, Andrea, a really impressive case. I have 2 short questions. After you used propranolol, it was discussed already a little bit, long acting. Do you think there's any place, any room for landiolol, the very short acting, just to get an idea, as long as you are not sure about the diagnosis? Do you think this is an advantage? This would be my first question. And the second one, only briefly, this denervation. We all know that it may reoccur, that it's, for some patients, it's not a definitive approach. Perhaps your comment on that.
Thank you for the question. For the first question, yes, probably is one of my questions that I had for another patient, for another case, not so, even not so malignant, or longitudinal type 3 with a neonatal that we make the diagnosis during the fetal life. And right now, I think that we don't try this. But ideally, it's a good option. It could be a good option to use denadolol in this type of patient for the different activation, no time of activation. And for me, it's one of the possibilities. But we never try this in our patient. So for this question, this is my answer. For the second question, it's a very good question. We have a lot of left cardiac sympathetic denervation. We do a lot of left cardiac sympathetic denervation with our team of thoracic surgeons. And this is, we don't have some recurrence of the after a left cardiac sympathetic denervation. It's true that they perform this at 8 days of life. So probably I think that during the probably in the next year we can have some something, probably there is something, the reinnervation or something similar that could be the idea, the possibility to do another procedure, or try to do another left cardiac sympathetic denervation. Thank you.
Thank you, Andrea. I will now introduce the third speaker, Manuela Lopez from Portugal, left pulmonary artery from the common carotid artery in the George syndrome, a case of ductal stenting as a bridge to repair.
Thank you very much for the introduction. I just wanted to be sure that you're watching the slides. Yes?
Yeah, all good, all good.
Okay, perfect. So, as it was said, my name is Manuela Lopes. I come from the Pediatric Hospital of Coimbra in Portugal, and it is an honor for me to be able to present our case, which we called left pulmonary artery from the common carotid artery in the George syndrome, a case of ductal stenting as bridge to repair. And as we know, discontinuous pulmonary artery itself is a very rare pathology, and I'm going to be more focused on the ductal origin of PA, which occurs in one of 200,000 babies that come. And so it is really, really rare to see this. And it is also, especially if it's a postnatal diagnosis, frequently mistaken for absent pulmonary artery, which is very dangerous, because if the duct will close, we can lose the perfusion of this lung, and there are a lot of long-term complications as it is expected. So early intervention is really important to support the growth of this disconnected PA, but unfortunately and frequently the size of these vessels are frequently inadequate for early reimplantation, and so we have to look for alternatives, and in our case we're going to try to show one of these alternatives. So our history, our case begins in the prenatal stage with a fetal echocardiogram performed at 22 weeks of gestation, where we found a right aortic arch associated with an aberrant left subclavian artery, but also, and this was the focus, a suspect of an LPA that came from the ascending aorta, so previously called hemitronchus. And this was also associated with an hypoplastic thymus. These are our images, as you can see from the first image in the upper part in the A picture. We had balanced cardiac chambers, and there was VA and AV concordance. But if you look more closely in the last two images, we saw that coming from the aorta, there was a vessel that was directed toward the left lung, and we thought here maybe this is not very normal, and this was also agreeing with an abnormal bifurcation of the PA, as you can see in the F picture, where we just found the right pulmonary artery, and so here we began to think this is probably an anomalous origin of the LPA. After this, and since we also had an hypoplastic thymus, we did the genetic tests, and this confirmed the presence of DiGeorge syndrome, which is very frequently found in these type of abnormalities. And we did serial echocardiograms that confirmed the previous findings, but also raised a small suspicion of isthmic narrowing. A baby boy was born, a term boy, weighing 2,970 grams. There was no need for resurrection, so an Apgar score of 9, 10, 10. And the physical examination was pretty much unremarkable. There weren't even any particular syndromatic features. We decided to do the admission in the ICU because we had that previous suspicion of an isthmic narrowing, so for surveillance, but the truth is this suspicion wasn't confirmed. But when we do the postnatal echocardiogram, as you can see from the picture, there is here a vessel that seems to come from the systemic circulation. We weren't really able at this point to trace the true origin of this LPA, but we thought it came somewhere from the ascending or aorta or supra-aortic trunk. The next images are the follow-up of this first echo, and as you can see, what worried us is this increasing Doppler gradient that reached 60 millimeters of mercury across this LPA. And also accompanying this, in the third picture, you also can see a very reduced left pulmonary venous return. And here we started to think there's something wrong here in this ectopic LPA. It seems to be narrowing, and can this be a ductal-depending LPA? Also, according to this, we did an X-ray, and as you can see, there is also an asymmetry of the lung perfusion, with the left lung being less perfused. And we decided to go with the CT to make sure that we wanted at this point to trace the origin of this LPA. And as you can see here in the moving image, I don't know if you can see the pointer, but if you trace, so there is an asymmetry in the lung perfusion and also the right aortic arch. But if you trace here the LPA, and I'm going to try to point it, I hope you can see it. If you trace here the LPA, which I'm showing here with my mouse, it becomes narrowed, and we can trace it to the left common carotid artery. Also seen here in the axial view, the same, but here in more detail, the narrowing part of this ectopic LPA. With this, we also decided to do, along with our image team, some nice reconstruction, 3D reconstruction of this vessel. And as you can see here in more detail, there was really a significant stenotic portion of this ectopic LPA. After this, we began to think with this new onset of stenosis, and we had previously a laminar flow on both prenatal and immediate postnatal imaging, is this a ductal origin? So what we decided to do, and to not lose the left lung perfusion, was to begin the prostaglandin. And the truth is, unfortunately, I don't have the images to show you, but the truth is, after initiating the prostaglandin, we had an improvement of the left venous pulmonary return, and also not totally normalized the gradient, but we had also a decrease in the gradient initially observed. After this, we began to think, what are we going to do after this? We need to re-implantate, do the re-implantation of this artery. So we decided to do a multidisciplinary approach, a discussion, and immediate surgery, unfortunately, and as you saw from the images, was not ideal because we had this stenotic vessel, which was also small, and we needed to promote pulmonary artery growth. So what we decided to do after careful consideration was a staged hybrid approach. So with 33 days of life, we took the baby to the cath lab, and as you can see from the first picture, we first confirmed the images that we already had from the CT. So as you can see in the main pulmonary trunk, there is only the perfusion of the right side when we do the angiography. And when we do also another angiography simultaneously in the carotid artery, and I tried to localize here the portion that I wanted to focus, you can see here a vessel coming from the left common carotid artery. And we were able to catheterize this vessel, and as you can see here in the last picture, the lung perfusion here was really, really reduced. So after this, we passed a guide wire, and as you can see here,
I ask you to go through conclusion because we are already.
Oh, sorry. Okay, I'm already. Okay. So we ended up putting an Ultimaster Negomi stent, and this is an image of this, and the lung perfusion got way better. And this is the control X-ray after the implantation, and as you can see, a significant improvement. The baby was under aspirin and oral diuretics when we discharged him, and the stent remained patent, and the gradient was first low, but after this it began to increase. And whenever the mother stopped diuretics, the baby got worse, and is currently waiting for a surgical reimplantation. Edward Double Aortic Arch explained this very elegantly, and what happened in our case was a regression of proximal sixth arch and the persistence of the distal portion, which led to the left DA that origined the LPA. And we already have a similar case, but in a follow-up patient. And here we have the origin from the carotid duct, which is a bit different from our case. We already have some cases of early reimplantation that went wrong, and we thought about this, and so we chose not to do it. And previous literature already support this ductal stenting as a bridge for a future reimplantation, surgical reimplantation. And as take-home messages, always search for ductal origin in an ectopic pulmonary artery. Early diagnosis prevents loss of lung perfusion, and hybrid strategies improve surgical outcomes. I'm sorry for the delay.
That was just 1 minute. Thank you so much. I will, if you stop sharing, then we can see the journey.
Yeah, of course.
Leave them to us. By the way, beautiful 3D reconstructions, really nice.
Yeah.
I have a question, if I can ask.
Silvia, please.
Yeah, Manuela, very nice presentation, very interesting case and challenging. I would like to ask, you have shown that the intervention, the stent implantation was done at the age of 33 days. So was the baby until then on prostaglandins, and why did you consider to do the intervention earlier?
The truth is, it was we didn't have the cath lab available to do it earlier. The prostaglandin wasn't immediately started. It seems like we did the diagnosis at 7 days old, and after that we initiated the prostaglandin. It was initiated more or less like in the second week of life, when we see the gradient was really, really high. And after that, we didn't take that much time to bring it to the cath. But the truth is, we didn't had an immediate, the cath lab wasn't available right away. And also we had a discussion of this, because in the beginning we did thought about an early reimplantation, but as we studied the EQ, there were bad results with this strategy, and so we ended up going to the cath.
Thank you. And what were the saturations before stent implantation, and did they increase after?
Yeah, surprisingly, the saturations weren't really that low in any point of time. I mean, we're talking about a newborn, so pulmonary pressures are still getting rearranged. But the truth is, he had never a significant desaturation. Although we were really worried about losing this lung, I think we were able to go to the perfect timing and avoid this worsening of symptoms and the cyanosis.
Thank you. That's all.
Thank you, Manuela. Well done. I've got a question from the audience, and then let's see if there are other questions from the jury. So Mohammed is asking, what is the proper age weight to consider surgical implantation of the LPA?
Yeah, that's an excellent question. This family wasn't the easiest, just to justify, because I mean, now we have a left lung being perfused at a systemic pressure, and so this is not the ideal situation. And of course, we want and we look to do an early intervention. The truth is, if it was just for the doctors who accompanied this boy, we would already had performed the surgical reimplantation, since the vessel seemed to have grown and has an adequate diameter. And so we were already thinking about doing this approximately before the first year of life. But the truth is, these parents weren't really easy, and so they are really afraid of the surgery. And although we already explained that this baby doesn't win with having this high pressure perfusion, they were reluctant, and that's why the baby hasn't done the reimplantation yet. But ideally, we would done it 6 months old after that.
Any other question from the jury?
Yes, Manuela, congratulations. I can tell you that I share similar patients, around 5 of them, some of them with below, some not, with pulmonary atresia. So it happens from time to time. You told us that you discussed multidisciplinary. I really like ducted stents, but they are in the end a palliation. Was there any, if you would not have succeeded, so there would have been an option to place a shunt to this pulmonary artery, to the left side, and was your surgeon concerned about doing the next step, the reimplantation with a metal thing in the pulmonary artery?
Yeah, of course. I mean, there's always a lot of distortion with the stents. And the truth is, in the beginning, of course, watching the CT images, I mean, the surgeons were already sweating, because it would be really difficult to have an adequate caliber and a pulmonary artery that could be reimplanted without getting stenotic after that. And so, although it wasn't something discussed, I mean, I think it's a really good alternative to do a shunt if it wasn't really possible to do the CAP. But the truth is, I mean, the ideal situation would be to reimplant it as soon as we can. But the truth is, when we are not able to do it. As you said, it is a palliative strategy, but it gains some time and it promotes the growth of the pulmonary artery, and we have seen this. And I mean, we are hopeful that although the stent is already there for some time, and I'm sure our surgeons will have some worries about this, but we are hoping that the final result will be a good result.
You proved success already.
Yeah.
So gained time for the baby. You got an increase of the diameter of the pulmonary arteries, so that's all good. Did you check for runoff, because it's very near to the aorta, to the left carotid? Did you observe any steal from there?
Now more than before. So in the initial images, you didn't have that significant steal. But now at the last evaluation, yes, there is some degree of systemic stealing. And so that's why, as I was saying, we were planning to do an earlier intervention. And because of the parents' reluctance, it wasn't done yet. But yeah, it is also worrying us.
Thank you.
Thank you.
Thank you, Manuela. Thanks to all the presenters and now outstanding presentation and discussion. I will give the word now to Jacob Giriste from United Kingdom. Sorry for my bad pronunciation of your surname. A narrowed path, successful percutaneous intervention for postoperative coronary artery stenosis in a child. Please.
Perfect. Thank you very much. Can I just check you can see my screen?
Thank you so much.
Lovely. Thank you very much. And as I said, my name is Jacob Gilchrist, and my presentation is titled A Narrow Path, Successful Percutaneous Coronary Intervention for Postoperative Coronary Artery Stenosis in a Child. So coronary artery stenosis following pediatric cardiac surgery is a rare but potentially serious complication. And although PCI is well established in adults, data regarding the use of PCI in pediatric cohorts remains limited. And as a result, there is currently a lack of substantial evidence surrounding the optimal revascularization strategies and long-term outcomes of using PCI in pediatrics. Where stenosis has occurred, the established indications for coronary intervention following cardiac surgery include prevention of adverse events like malignant arrhythmia or sudden cardiac death, presence of angina symptoms, or evidence of myocardial ischemia. And surgical revascularization has historically been the preferred approach. However, long-term outcomes remain variable, and there's uncertainty regarding long-term graft durability, impact on quality of life, and potential need for repeat interventions with growth. In terms of our case then, a 5-year-old child first presented to their local hospital with a 2-month progressive history of cardiac failure, including symptoms of poor feeding and weight loss, lethargy, and reduced exercise tolerance, alongside a 2-day history of respiratory distress. There was no past medical or contributing family history. An examination showed a grade 3 pansystolic mama with radiation to the carotids, alongside hepatomegaly of 3 centimeters. Initial workup included an ECG, and just to note, this ECG has reduced voltages on it, but it showed normal sinus rhythm with subtle infralateral ST changes. Chest X-ray showed gross cardiomegaly, and this was alongside raised cardiac markers, including troponin I, creatinine kinase, and NT-proBNP. However, inflammatory markers at this point were normal. As a result, an echo was performed, which showed a large aortic root aneurysm with a Z-score of plus 2.3. And on this image here, you can see that the aneurysm is large and posterior to the aortic valve. Physiology is in keeping with an aortoventricular tunnel, and this was alongside severe aortic regurgitation and impaired left ventricular systolic function, with Simpson's biplane calculated at 49%. As a result, the patient was admitted to Great Ormond Street Hospital and underwent an aortic root replacement with homograft and aorto LV tunnel closure. However, following this intervention, the patient had a turbulent and difficult postoperative journey with ongoing concerns about the right coronary artery. So they were initially commenced on and completed a prolonged course of IV antibiotics for gram-negative bacilli that was positive on AV tissue samples. And as said, in the postoperative period, they had persistent ST segment changes on ECG, alongside post-op echo that showed impaired biventricular function with flow acceleration at the origin of RCA, suggesting stenosis. As a result, day 2 post-op, they underwent an emergency coronary angiography before undergoing an initial aortic root augmentation and then subsequent right coronary artery reimplantation, where at this point it was noted that there was angulation at the right coronary artery ostium, again reflecting the persistent issues that the right coronary artery presented during the submission. These repeat interventions did resolve ECG ST segment changes, and post-op echo pre-discharge showed a patent right coronary artery ostia with good flow in proximal and distal portions. So after 3 total surgical interventions, the patient was discharged home 28 days from initial presentation. They then had serial follow-up, at which point initial echoes had difficulty assessing the coronaries but could see some forward flow. However, following this, repeated ECGs showed ST depression in inferior leads, and so an advanced echo was arranged, and this is an image from it, in which you can see that the right coronary artery is visualized on 2D imaging, but no flow can be visualized with color Doppler, despite extremely low Nyquist. It's also worth noting at this point that the echo reported reduced right ventricular longitudinal systolic function with a reduced TAPSE. Further workup was done then, including a CT angiography, which confirmed RCA occlusion over a 4 to 5 millimeter segment. And at this point, it was also raised that there was possible LCA collateral supply due to apparent retrograde right coronary artery filling. Other workup included a stress MRI that was positive, showing inducible perfusion defects in basal and mid-inferior septal segments of the left ventricle. And crucially, exercise testing showed dynamic ischemic changes with changes seen in inferior and lateral leads at peak exercise that can be seen here. It's worth noting at this point that the patient had remained completely asymptomatic throughout their follow-up period, hence the extent of investigations that were done to ensure an appropriate indication for any intervention. 23 months post-procedure, the patient underwent a coronary angiography that showed significant right coronary artery stenosis without adequate collateral perfusion. It was at this point that conservative management approaches were commenced, including exercise restriction and beta blocker therapy. And at this point, further MDT discussions were had, which this time included adult interventional cardiologists with an expertise in PCI and managing chronic total occlusion. And following significant amounts of collaboration, the MDT agreed to proceed with percutaneous coronary intervention to the right coronary artery, essentially managing this as a chronic total occlusion. And so, aged 7 years and 10 months, the patient underwent transluminal balloon coronary angiography with proximal right coronary artery stent implantation. And these are images from the cath data, where the image on the left shows at the beginning of the procedure, and you can see an area of proximal occlusion in the right coronary artery. And then the image on the right is following balloon dilatation and insertion of the drug-eluting stent, showing marked improvement in coronary flow. The overall result was excellent, with a minimum stent area of 5.6 millimeters squared and greater than 90% stent expansion. There were no procedural complications. Post-op echo showed preserved biventricular function and ECG normal sinus rhythm. So the patient was commenced on a 6-month course of dual antiplatelet therapy with aspirin to continue for life and discharged home 24 hours post-procedure. They've since had their initial 6-week follow-up, at which point again echo showed preserved function with antegrade flow in the proximal right coronary artery. And so at this point, previously imposed exercise limitations are lifted and beta blocker therapy was discontinued. There's also been booked for a repeat exercise test and Holter test and repeat CT angio in 6 months' time. So as discussed in the introduction, limitations exist with current surgical approaches to coronary revascularization in pediatric patients. And although PCI is less invasive, data on its outcomes remains scarce or highlights the technical difficulties with performing percutaneous coronary intervention in pediatric cohorts. For example, a retrospective review in 2022 of 24 pediatric patients who underwent percutaneous coronary intervention for coronary artery stenosis or fistula reported a significant procedural risk and in-hospital mortality in 25% of patients, with a 5-year survival of 62.5%. Additionally, long-term effects on functional outcomes and quality of life remain poorly characterized in pediatric patients post-PCI. In our case, input from adult interventional cardiologists helped overcome technical challenges that included small coronary vessel caliber, altered coronary anatomy following surgical reimplantation, and the need to achieve durable revascularization in the growing child. The ultimate result is successful revascularization and restoration of coronary perfusion, with substantial improvements in quality of life as beta blocker therapy has been withdrawn and previously imposed exercise restrictions were lifted. The intervention also importantly addressed objective evidence of inducible myocardial ischemia and reduced the potential risk of adverse cardiac events. So overall, this case demonstrates the successful treatment of chronic proximal right coronary artery stenosis in a child without congenital coronary anomalies. Our learning points are that PCI in pediatric patients is rare, but may be indicated for postoperative coronary artery stenosis, although data on long-term outcomes is limited. Multimodality imaging is essential for identifying clinically significant coronary stenosis and guiding revascularization decisions, and collaboration between pediatric and adult interventional cardiologists can help overcome technical challenges. These are some of our references, and thank you very much for listening.
Thank you very much, Jacob, for staying in time. I'll give the words to the jury. I can see already there is a question in the question box, but I will start with the jury. Maybe it's better.
Yes, Jacob, this situation with closed coronary arteries, the heart rate and the pulse pressure of the investigator always goes up. So I have some questions for you. You told us about the redo operations, and I didn't get it correct that it was the redos were based only on echo findings, or did you do CT scan or MRIs or whatever also for?
So they had the initial procedure and then remained admitted throughout that period. They initially had echo that showed the impaired biventricular function, and ECG changes were seen whilst they were admitted in CICU. So day 2 post-op, they had an emergency coronary angiography that confirmed an area of stenosis within the RCA that led them initially to perform a patch augmentation. That was an attempt. It was seen during that procedure that the right coronary artery could pass a 2.5 millimeter probe. So they thought to try and they first performed the aortic patch augmentation to try and relieve some of the stretch that they thought was occurring in the right coronary artery. And then once kind of echo and ECG findings were persisting, even despite that, the next day they went back for right coronary artery reimplantation.
Okay. And I have 2 more questions for you. One is the surgeons, they are quite experienced in doing bypass surgery from the internal mammary artery. In Kawasaki patients or whatever. Did you ever discuss that it could also be, could have a bypass surgery?
Yeah, so the prospect of that and using kind of a rim graft to assess the coronary stenosis was discussed extensively during kind of multidisciplinary discussions. I suppose there are a couple of reasons why it didn't go ahead. I suppose one was the surgical aspect. So as we said, this child had 3 kind of surgical intervention initially, and it was felt that kind of any further bypass to do a reimplantation of that coronary artery was going to be very difficult and suboptimal. In terms of the REMA graft, then it's discussed that sort of what the longevity and durability of that REMA graft would be in a child who is 6-7 years old. When we looked at kind of adult data, it was seen that the durability of that could be about 10 to 20 years. But for a child who's 6 to 7 years old, it was difficult to extrapolate. And so it was felt that ultimately that option was suboptimal. The other option or the other consideration was from a kind of quality of life perspective. We looked at, there's kind of some evidence from Kawasaki disease patients who, from a long time ago, who have said that even with good graft patency after a CABG or REMA graft, sometimes exercise limitations can still remain in place. And it was felt from the patient's perspective, from the family's perspective as well, that might be an issue as the child gets older. And so discussing with the adult interventionist who said that, you know, whilst this was a risky procedure, that there would be a good chance of success, that could hopefully enable them being able to lift exercise limitations, which we have been able to do.
But my final question would be, you showed us pictures that between the second and the last, or between the last surgery and the intervention, there was quite a good collateralization. So the myocardium was preserved in a way. But if you now establish this antegrade flow, these collaterals will go away. Haven't you been scared for that? Because the child can outgrow this stent diameter.
Yeah. And so is this about the left coronary artery collaterals in particular? that was initially seen on the CT, that they raised that there was possibility of left coronary artery collaterals. When they then performed the at 23 months post-procedure, the diagnostic coronary angiography, it was seen that there was no collateral supply. That it was actually a very narrow portion of the right coronary artery was receiving antegrade flow, which again probably explains why the patient had remained asymptomatic, but there was evidence of kind of dynamic changes with ischemia. It's just a very narrow area that was receiving antegrade flow. So in terms of the question of, in the long term, whether this stent will need re-intervention, whether they can outgrow it, that's definitely was a consideration. I suppose I kind of said there was the dilemma about whether to perform, that performing a remograft or another bypass operation was suboptimal, and that this procedure, whilst in the future, say for example, the aortic homograft will have to be readdressed at some point, and that the stent, they might in the future need a remograft. In the interim, this could effectively buy the patient some time and allow some normalization of their quality of life in that interim period.
Thank you, Jacopo. I will just ask you the two questions from the chat box. The first one from Domenico Siriaco was asking, did you consider to do a coronary angio and an invasive FFR investigation? This could potentially have accelerated the diagnostic and interventional process. This is the first question.
Yeah, I suppose that's addressing the kind of in between the kind of post-submission pre-PCI. I suppose the reluctance to go ahead straight away with the coronary angiography was that the patient remained asymptomatic. So up until 17 months post-procedure, some of the initial echoes had shown good flow through the coronaries. ECGs had been sort of in range of patients asymptomatic. It was only at the point when the advanced echo was done that there was no flow seen through the right coronary artery. And again, at that point, further workup was done. I suppose that workup was done prior to an eventual coronary angiography, which was done at 23 months, kind of post-procedure prior to the percutaneous coronary intervention. But there was a coronary angiography that was done.
Okay. And then Paul Silis was asking, did I understand correctly, did you do an X-ray test on a 5-year-old boy? How was the compliance? Was it manageable?
Yeah, so the patient is now getting to an age where actually we could look at doing a stress echo. They're approaching about 8 years of age, and that's something we will be doing in the future. With regards to the exercise testing, we did actually have really good results. So the ECG was, these should show kind of good dynamic changes, especially at peak exercise. So that kind of inferior and lateral leads. The patient was able to comply with that. I suppose there can always be difficulties surrounding that, but we were able to get kind of findings that demonstrated objective myocardial ischemia, and that was kind of done within the protocol that we have at the hospital in the echo department.
Good. I'll just ask the jury if there is another question, so Silvia?
Can I ask one question, please? Jacob, very nice presentation of very nice case. I would like to ask a question. Do you know if the MRI has been done under general anesthesia? Because it's stress perfusion, the compliance may have been not so great. And do you know which agent has been used for this purpose, for the stress perfusion?
Yeah, great question. In terms of under GA, as far as I'm aware, I'd have to double check exactly, but I think it was done under GA. The patient was kind of done as a day case, but it was done under GA as far as I'm aware. As to the exact agent, I'm not exactly sure of what the protocol that was used for that specific one.
Maybe Thank you.
Thank you. So I think I will move on now to Roberta Di Cosola, our last speaker. Roberta is from Italy, and I'll just read the title. Left ventricular dysfunction and massive intracavity thrombus in unrepaired cardiac low with endomyocardial fibrinostosis, a case report.
Hello everyone, thank you. First of all, thank you for this opportunity to present this case. So first of all, tetralogy of Fallot is a well-known cyanotic congenital heart disease that thanks to early diagnosis and surgical repair techniques has an improved outcome. However, it is still possible to find patients with unrepaired tetralogy of Fallot, but it's quite rare to present to the presence of severe left ventricular dysfunction in these patients, and even more rare, the presence of left ventricular intracavitary thrombosis. So we present this case of a 9-year-old boy coming from Cameroon with a diagnosis of unrepaired tetralogy of Fallot. In his history, we found progressive exertional dyspnea and many episodes of hyperstenotic spells. The mother told us to find him usually frequently assuming the squatting position, and in the last years he had presented recurrent febrile episodes. On admission, he was severely desaturated with an oxygen saturation of 60% in room air. He was apyretic, he had mild exercise intolerance, and the exams showed severe erythrocytosis with an hemoglobin of more than 25 and an hematocrit of more than 65%. And this was his chest X-ray. So we performed an echocardiography that confirmed the presence of the features of the tetralogy of Fallot, but we also found a severe left ventricular dysfunction with an ejection fraction of 15%, and also the presence of mass at the apex of the left ventricle that was suspicious for thrombosis. So we went on with investigation, and we performed a CT scan that confirmed the presence of a large endoluminal filling defect that was adherent to the anteroseptal and infralateral walls of the left ventricle that almost obliterated the apex of the left ventricle, and the coronary anatomy was normal. Then we performed a cardiac CMR, not only to study the mass, but also to evaluate the myocardium, and the late gadolinium enhancement showed us the presence of late LGA involving the anterior, lateral, and inferior walls of the mid-apical segments of the left ventricle that was consistent with endomyocardial fibrosis and was also suspicious for endocardial fibroelastosis. So we performed an extensive infectious workup, including especially for the parasitic infections, but they were all negative. We performed a CT brain scan that excluded secondary embolism. We started anticoagulant therapy, and we went on with the surgical program with the surgical repair of the TOF with transannular PET and the removal of the thrombus that was histologically confirmed. After the repair, the patient developed cardiogenic shock with a severe biventricular dysfunction and severe atrioventricular valves regurgitation, so he needed a temporary mechanical circulatory support through ECMO that was later weaned thanks to the inotropic support with levosimendan and mirvenon. After that, heart failure therapy was titrated with beta blockers and ARBs, and anticoagulant therapy was continued with warfarin. At 3-month follow-up, the function improved and there were no more signs of thrombosis, so we stopped the anticoagulant therapy and we keep the heart failure therapy. So in this case, we have left ventricular dysfunction that is a well-known independent predictor of adverse cardiovascular events in repaired tetralogy of Fallot. However, in unrepaired tetralogy of Fallot, it remains uncommon and should prompt further investigation for additional myocardial abnormalities, which were negative in our case. So we suppose that the left ventricular dysfunction was due to the chronic hypoxemia that may lead to myocardial ischemia, the chronic right ventricular pressure overload that may had contributed to the ventricular interaction and alterate the left ventricle geometry, and also the activation of the neurohormonal pathways that have maybe had played a role in the myocardial remodeling. Another point in our case was the presence of a thrombus in the apex of the left ventricle that reminds us of the Virchow's triad that explains the thrombogenesis through the three aspects that are the blood stasis, in our case due to the severe left ventricular dysfunction, in particular of the severe hypokinesia of the apical segments, the endothelial injury provoked by the endomyocardial fibroelastosis due to endothelial to mesenchymal transition, and the hypercoagulability state provoked by the erythrocytosis secondary to chronic stenosis. Finally, the key role of multimodal imaging that allowed us to interpret the complex interplay between congenital anomalies and secondary pathophysiological alterations to plan the treatment and to follow up. And the remarkable recovery of ventricular systolic function that we observed in our patient maybe suggests that chronic stenosis may have some rate of reversibility after hemodynamic correction. So in conclusion, severe left ventricular dysfunction in patients with unrepaired tetralogy of Fallot is uncommon and should prompt investigation for additional myocardial exopathology. Chronic stenosis, ventricular dysfunction, and endocardial abnormalities may promote intracavitary thrombus as described in Virchow's triad, and multimodality imaging plays a crucial role in the evaluation and treatment planning of complex congenital heart disease. Thank you.
Thank you very much, Manuela. I'll just wait you to stop sharing and let's see if the jury has any questions.
Yes, I would not be the only one who asks questions, but I have a question for you concerning atrial fenestration within the surgery, because it must have been expected that the left ventricle eventually will fail because of this diastolic dysfunction. Did you place an atrial fenestration either during surgery or when you put him on echo? Because
the surgeons left an open fenestration in the interatrial septum because we were afraid of the inability of the left ventricular to improve and to sustain the circulatory system. So yes, it was open.
And was there any preventional things the surgeons did not to allow embolization during surgery of this thrombus formation to the brain?
I think they, actually this question is correct for the surgeons. I think they removed all the, as they opened the heart, they removed all the thrombus, and thanks to the severe hypokinesia and the absence of previous cerebral embolism, we were pretty confident that the risk was not so high secondary embolization. But yes, the fear, there was this fear, and but thanks, there were no secondary embolization to the brain.
There are some perfusion techniques that may protect. I don't know. I'm not too familiar. And one last question: which medication is the patient on to allow preservation of the heart function?
Yeah, they are. He is on beta blocker, bisoprolol, and Romipr, ARBs, and spironolactone. And actually, he's back in Cameroon, so he's keeping this therapy. He's just stopped warfarin, and this case was done 2 years ago, and he's pretty well in this therapy.
Yeah, I just was interested whether you use one of these FEP for the SGLT2 or something else because of the diastolic aspect. But thank you very much.
Thank you.
Thank you. Any other questions? Colin, Sylvia, are you happy? Okay.
Maybe one short question. I'm always interested in fellow ECGs. Were there any anomalies? Most expectedly, there will be something like curious broadening and other aspects that then, on the long term, but only later, show a high risk for arrhythmias, for example.
Yeah, before the surgery, he had just severe biventricular hypertrophy. After that, we had a complete right bundle branch block, but the chorus was not fragmented. So, so actually from DCD, we had no signs of high risk for arrhythmias. And during his stay here in the hospital, he had no major arrhythmic events. And thanks to the improved left ventricular dysfunction, we decided to not insert any device.
Very good, thank you.
Thank you. So I think we have arrived at the very end of this clinical case competition webinar. What we're going to do now, unfortunately, we will take out the connection with the people that are in the audience just for technical reasons, and the jury will make their vote. We will call back all the juniors here in the call, so you just have to use the same link that you use now. So we will tell you who is going to be the winners and the 3 luckiest ones that will have the possibility to publish in the journal. But we have really good surprise for all of you. Tomorrow you will receive an email with the name of the winners, but for who is in the WhatsApp group of the juniors, I will anticipate the names of them. Just a quick question, juniors, I mean Roberta and everyone, are you in the general WhatsApp group, so I can send you a message there to connect, or otherwise I'll send you an email from so I'll tell you when to re-enter. Okay, I will put a message in the general WhatsApp group and then send also an email. Okay, fine. So I will ask you just to go out, and I think I need to ask Linda to take up the connections with the participants, or I will ask the participant to go out if they can. Thank you so much. So Roberta, Manuela, Maria, just go out from the meeting so we can decide, and then I'll call you back later. Okay?
Thank you.
Thank you very much. Okay, the participant going down now. We still have someone connected. Let me see how I can do this. No, I'm just asking the participant to go out. So we still have 25 people inside. Thank you guys. I know you would like to be connected, but I really need to ask you to go out from the call. Thank you very much.
Already, it's not so easy. I have to remove them one by one.
Okay. Probably some of them.
It's okay. No, it's okay. Maybe.
They don't want to leave. That's a good sign.
They don't want to leave. Yeah. They're curious.
Oh, what have we done?
They will be gone soon.
Thank you, Linda.
Yeah, it takes a bit of time. I'm sorry.
No, don't worry.
Unfortunately,